Hello and welcome to watch my vlog of sports injury discussion. First, let's talking about a scenario. In a football match, two players collide, causing them to fall to the ground. The fallen player's right ankle is caught between the opponent's legs and the turf. The player immediately reported the pain around the ankle to the first aider. Further examination of the player in A&E by ultrasound and clinical examination revealed a rupture of the anterior tibiofibular ligament in the right ankle. Firstly, I will give an introduction to the rupture of the ATFL. The ATFL originates from the anterior border of the ultrafibular and attached to the talar neck. The function of the ATFL is to resist the inversion and the plantar flexion of the ankle joint. Injuries to the ATFL usually occur when the athlete's weight shifts to the lateral border of weight-bearing leg, causing the ankle to roll inwards at high speed. The ATFL is the weakest of lateral collateral ligaments and is therefore the first to be injured. Mechanisms of injury may include landing awkwardly on an opponent's foot, outside of the foot gripping the terrain of the ground, or contact with the inside of an opponent's weight-bearing leg while sliding the shovel. This fits with the content of the scenario we mentioned at the beginning. Ankle sprains are one of the most common injuries affecting the ankle ligaments. Common symptoms associated with acute ankle sprain include pain, lack of range of motion, lack of posture control, and muscle weakness. Besides isolated ATFL injury and combined ATFL and CFL injuries occur in 80% and 20% of ankle sprain respectively. When a patient presents with possible symptoms, a full physical assessment should be performed to further confirm if it's an ATFL injury. The first thing to look for is any major abnormalities, such as edema and PDG. This is followed by palpation of the ATFL and other areas of tenderness of the lateral collateral ligaments. Edema can be measured in a figure of 8 using the tape measure, including the medial malleolus, lateral malleolus, navicular bone, and the base of the fifth metatarsal. For range of motion, a goniometric can be used and should include both active and passive range of motion. There are also some special tests that can effectively detect damage to the ATFL. For example, in the anterior drawer test, the tibia and fibula are stabilized with one hand, while the foot is in hold in plantar flexion at 20 degrees with the other hand, and the talus is pulled forward into the ankle socket. A positive test result is obtained when the anterior movement is greater than 5 mm compared to the uninjured ankle. This may indicate joint laxity due to ATFL or CFL ligament tears. An audible crackling sound may also be present during the test. The anterior jaw test has been found to be significantly more sensitive when performed 4 to 5 days after injury due to severe pain and swelling. Further assessments may include imaging to assess ligament damage. Radiographies based on the Ottawa principle may show excessive anterior displacement of the talus or inversion of the talus. In addition, ultrasound and MRI are commonly used to diagnose associated injuries. Preventing and avoiding ATFL injury requires an understanding of the risk factor for injury to occur. Factors that have been shown to increase the risk of ATFL injury including gender, weight, heat, ankle laxity, muscle strength, proprioception, and the muscle reaction time. The most important risk factor for ankle sprain is reduced stability due to reduced proprioceptive function, leading to a previous ankle sprain. Some reports have shown that the use of balanced boulder training can significantly reduce recurrent injuries in previously injured ankles. Therefore, members of the MDT, such as coaches and rehabilitation therapists, should advise athletes to complete a supervised balance training rehabilitation program. However, it is controversial whether such training is beneficial in preventing sprain in normal healthy ankles. In addition to exercise therapy, there are other areas in which ATFL injuries can be prevented and avoided. In terms of functional sport, there is level 1 advice that the use of brace or tape can reduce the risk of recurrent and first-time ankle sprain. There is also evidence that kinesio tape is helpful for posture control and therefore prevents ATFL injury. Many studies have reported that kinesio tape can increase sensory input and proprioception. And Konish's report also shows that the use of tactile stimulation via kinesio tape can improve muscle activity in injured patients. Now we're moving to the immediate management. First aid measures are usually taken by a professional team consisting of multiple disciplines and specialties, with a relatively high-quality team members with excellent professional skills and need emergency awareness, who can understand the patient's injury pattern, injury tools, injury location, and focus from the observation process and make a comprehensive analysis to make a correct injury assessment and improve the success rate of resuscitation. In the event of a player injury, emergency service should be called immediately, and an ambulance should be called as appropriate. First aid should begin with a primary survey on the sidelines, include Dr. ABC. Firstly, we should check the environment for hazards. Ensure safety as first aider approach. After that, assess the player's response, patency of the player. In the case, the player immediately reports pain around the ankle to the first aiders, indicating that he can still talk to the first aiders. Therefore, the airway and breathing are fine. First aiders are going to use splint to immobilize the injured person's ankle and observe the color of the skin and the capillary refill time for 5 seconds to check the circulation. At this point, players should be immediately removed from the field of play. Then secondary service can be conducted on the sidelines to help diagnosis. First aiders need to check for any other areas of disability. Signs for trauma, bleeding, skin reaction, needle marks, and so on must be observed in the case of exposed skin. The doctor can make a further diagnosis by medical history, physical examination, and special tests. The examination begins with looking for swelling, severe deformity, or significant asymmetry. Palpate bone landmarks and look for local tenderness over the ATFL. Active and passive range of motion assessment of the ankle should be assessed as pain permits and compared with the contralateral side. A full neurological assessment, including power sensation and the reflexes of the lower limb, should also be performed to rule out fibular or gastrocnemius nerve involvement. In addition, the distal dorsalis pedis and the tibial artery pulsation should be examined to assess vascular injury. Special tests like anterior jaw testing may show joint laxity due to a torn ATFL ligament. It is important to document weight-bearing status and pain levels which, according to the Ottawa ankle principles, to screen for athletes that should get an X-ray after ankle sprain, may affect the need for imaging and clinical procedures. Stress radiographs may show excessive anterior displacement of the talus or inversion of the talus. Early examination is important to triage for more severe injuries, such as fractures. To alleviate the painful situation of the injured person, some emergency measures can be carried out right on the sidelines. The first step should be to rest from activity. Cryotherapy should be used immediately around the pain area. Heat should not be applied to an acutely injured ankle joint because it encourages swelling and inflammation through hyperemia. Crushed ice in a plastic bag may be applied to the lateral ankle over a thin layer of cloth. Alternatively, the foot and ankle may be cooled by immersion in water at a temperature of approximately 12.7 degrees. The foot and ankle should be cooled for approximately 20 minutes every 2 to 3 hours for the first 48 hours, or until edema and the inflammation have stabilized. To squeeze the edema fluid out of the injured tissue, the ankle should be wrapped with an athletic bandage to increase pressure. Next, the injured extremity should be elevated 15 to 25 centimeters above the level of the hurt to facilitate venous and lymphatic drainage until the swelling has begun to resolve. Besides, anti-inflammatory drugs are preferable for pain relief. For better recovery, injured athletes must avoid heat, alcohol, running, and massage for 72 hours. A general diagnosis of the type and extent of the injury can be made by observing the athlete's symptoms and taking a medical history. The patient in this case was not in an emergency and could have gone to hospital on his own without the need for an ambulance. The diagnosis was confirmed in hospital, and a lengthy period of treatment was required before he could return to the field. The exercise program for the treatment of ankle sprain consists mainly of neuromuscular and proprioceptive training. Range of motion must be regained before functional rehabilitation is initiated. Exercising range of motion can be done in 3 stages. Stage 1. Use an elastic band to pull foot towards face. Pain-free stretch for 15 to 30 seconds. Stage 2. Stand with heel on floor and bend at knees. Pain-free stretch for 15 to 30 seconds. Stage 3. Move ankle in multiple planes of motion by drawing letters of alphabet. Repeat 4 to 5 times a day. Once range of motion is achieved and the swelling and the pain are controlled, the patient can move on to the intensive phase of rehabilitation. Strengthening weak muscles is essential for rapid recovery and is important to prevent re-injury. Strengthening begins with isometric exercise performed against an immovable object in 4 directions of ankle movement. The patient then progresses to dynamic resistive exercise using ankle weights, resistant bands, or elastic tube. When the patient is fully weight-bearing and pain-free, proprioception training is started to restore balance and posture control. Toe raises, heel walks, and toe walks can also be used to try and restore strength and coordination. The simplest device for proprioceptive training is the wobble board, a small discoid platform attached to a hemispheric base. The patient is instructed to stand on the wobble board on one foot and shift his weight, causing the edge of the wobbleboard to move in a continuous circular pace. In addition to exercise therapy, manual movement of the ankle is beneficial in obtaining range of motion and pain relief. TENS post-ultrasound, anti-edema massage, and low-level laser may help in reducing inflammation. The acronym PAASS summarizes the areas that should be assessed to determine when an athlete is cleared for unrestricted training and return to competition. P for pain during sports participation and within the last 24 hours. The first A for ankle injury include range of motion, muscle strength, endurance, and explosive power. The second A for athlete perception include perceived ankle confidence. The first S for sensory motor control include proprioception and balance, and the second S for function performance include jump, hopping, and sports-specific training and ability to complete a full training session. Both emergency measures and long-term management requires a multiple disciplines team. The members of the MDG can be roughly divided into 3 categories. The first being epidemiologists, coaches, and athletic trainers. Epidemiologists can provide early warning of injuries. Coaches and athletic trainers are the first to be able to identify and manage athletic injuries. And in particular, athletic trainers, the first medical professional to be licensed to assess an athlete's injury and provide emergency management. The second category of personnel is doctors. Sports medicine doctors are often in a leadership position, working with professionals from other disciplines throughout the care process of ensure the best interests of the athlete. Physicians also play a leadership role in the management of sports injuries and the development of plan. The third group of personnel includes physiotherapists, psychologists, nurses, dietitians, and others. They are involved in all components of the sports injury management program, managing, assessing, and rehabilitating patients physically and psychologically. Although some disciplines may be more involved in the different stages of injury management, all healthy care professionals work together at almost all stages. Thank you for listening my MSK discussion blog.